Welcome to the Stat AI podcast.
Welcome to the future of emergency medicine, a realm where artificial intelligence isn't just a buzzword, but a beacon of hope and a tool for transformation. I'm DJ Apakama. My co-host Ethan Abbott and I are both emergency physicians, and we have witnessed firsthand the burgeoning role of AI in our field. Our everyday experience grappling with healthcare disparities and social challenges have led us to a pivotal question. In the wave of AI applications, what changes are coming to emergency medicine, and will they be for the better? This podcast was born not just to ask these critical questions, but to seek out answers from the experts, to understand and to demystify the potential of AI in emergency medicine. We believe in bringing this conversation to the wider community to embrace AI as a tool for positive change. This podcast is our exploration of that future, a journey we invite you to join. So let's embark on this path together to learn, to question, and to envision a new era of emergency medicine enhanced by the power of AI.
On this episode of the Stat AI podcast,
The thing about AI, well, one of the many things about AI is that it makes us relook at everything, right? We have built medical education, training, etc., around the premise that you must maintain a certain amount of knowledge in your brain. Well, now we are moving to this era where the people that can integrate this tech into their practice the most seamlessly are going to be the most successful.
hey DJ, how's it going today?
How you doing, man?
Doing great. I'm excited for episode 9, where we talk with Dr. Tyson Pillow about all things AI and medical education. But today, I think we wanted to pivot a little bit, and instead of discussing a research article, to maybe talk about some of the tools that we or you are using now in research and potential clinical applications. So I think we wanted to talk a little bit about this model context protocol on the Claude desktop app and how you're using it and how that could potentially be integrated into maybe research or clinical applications. You want to tell us a little bit about what the tool is for our listeners first, and then maybe how you've been using it and some ideas for future downstream use cases?
Sure. I think it's one of those things where, does anyone else find it ironic that in 2024, you can ask your smart home assistant, Alexa, Siri, whoever, to order a pizza, and it's going to come to your apartment with high fidelity, but you still have to click 17 times to get a basic blood count? I think that these types of things, it's like we're seeing progress in one arm, and then sometimes in our jobs, it feels like it's really not matriculating. I do think that the model context protocol, here forward just referred to as MCP, it might change those things, and not necessarily in its current iteration, but again, this is an eye to the future. So it's Anthropic's new open standard that lets an AI system directly interact with your data and tools. So you can think about your daily life outside of the hospital, where your calendar app, your to-do list, the spreadsheet where you track your kid's soccer schedule, even your Spotify playlist. MCP would let an AI system understand that and work with all of these data streams simultaneously in the proper context. So let's say, again, back to the out of the emergency medicine for a second. You're planning a family vacation. It can check your calendar. It can check your budget spreadsheet, local school schedules all at once. And so that you're not toggling in between different tabs. Or you could be doing something like a home renovation. It can pull up your Pinterest boards, cross-reference them with your Home Depot shopping list, and check your project management tools, all while understanding how these pieces actually fit together. So this is where it gets interesting for us in emergency medicine. The same principles could revolutionize how we handle clinical data. Instead of treating your EMR, your PAC system, and departmental databases as separate islands, with a little bit of tweaking in the future, MCP could potentially let those systems work together seamlessly while maintaining all the security and privacy requirements that we really depend on in healthcare. So even if you think about like your last quality improvement project, how many hours did you spend just gathering data from different systems? And that's exactly the kind of problem that MCP is built to solve. So before we dive further kind of into healthcare application, I think it's interesting to just pause there and say that for me, again, I'm not using this for sorting through HIPAA compliant databases yet, because you do need a HIPAA compliant model context protocol. And right now, this is really only allowed on the desktop model, a desktop version of Claude that you can get through on Mac OS. So it's available to anyone who wants to try it.
What have you been testing it on and trying it out on to see how it works outside of clinical applications?
Right. For me, we both are very engaged academic emergency physicians. So I have been using it to organize research papers. And that sounds like a trivial use case for all the powers and potential kind of future protocols and use cases that I just mentioned. But for me, I spent a great deal of my life trying to organize papers into nice little folders in my desktop. This was something that I really wanted to see if it could handle, right? And if you think about that folder, paper to read, on your desktop, it's eternally ignored. MCP has been helping me fix that. You create a simple server that you can connect to your reference manager, which will then let Claude read through your PDFs and can automatically organize them into a structured database. And the best part is that it's basically as technically demanding as creating and installing Spotify, albeit with a little bit of command line code. But the command line code, you can actually get help from, pick your LLM, Claude, GPT, Gemini, whatever, to help you if you're not comfortable kind of using command line code.
What's the end goal of this project? What do you want to do with this in terms of just organizing the research literature, or how do you see it taking it to the next step with MCP?
No, that's a great question, right? And so for me, a lot of if you can think about creating a systematic review on demand with the right context within about 5 minutes. Like that,
Wow.
That's where this is going. And that you're going to have to go through, obviously, and verify everything that's being done. But essentially, your reference manager, right, the tool that you're using to manage papers anyways, is what this is connecting to. The chances for hallucination, at least so far that I've found, are not that high. But again, that's just one way to use this. I think, to put it in plainer terms, what MCP is allowing you to do is take the already outstanding native language model that powers Anthropic's Claude, add search capabilities, deep search. So searching not only the web, but you can actually search local businesses. And then you're also adding the ability to create repositories, pull in code from GitHub, add it to your particular application, run it in real time in kind of their context window so that you can edit it and make changes to it, the code itself, before you now then ask it to create the application. And when you ask it to create the application with MCP, what's different than the ChatGPT, which will spit out the code for you, is now MCP actually has access to the files on your computer, on your GitHub server, so it can just push that code directly to where it needs to be.
That's amazing. That's so cool. How do you picture this like in the emergency department? What would be like a cool application of this, do you think?
So I think maybe even slightly above the emergency medicine kind of viewpoint, I think this is really great for a system, right? So a health system who has a lot of moving parts, maybe a lot of different clinical locations, and obviously different types of specialties. When we're thinking about kind of understanding problems at the health system level, you need a lot of data points. And so for me, thinking about things like how do we respond to surge or tracking kind of early disease outbreaks, right? It is going to be cobbling together these disparate data streams, whether it's information from EMS or information from the Department of Health or your actual EMR, right? Now, integrating all of those sources and asking a question like, should I be getting more ventilators? Should I be getting more blood culture tubes, right? All of these things, these random problems that seem to be based around constraints in, if not data, maybe supply chain. I think there is a chance that, again, if not MCP, something similar into its architecture or end goal will end up solving kind of these siloed data stream problems.
That's amazing. And we should note we're not sponsored by Anthropic, although we would happily be sponsored by anybody, but we are not sponsored by them and not endorsed by them. So just want to make that clear. But that's amazing. Thank you, DJ. We're going to pivot now to the interview with Dr. Tyson Pillow.
All right. And we are so happy to have with us today Dr. Tyson Pillow. He is a professor of emergency medicine and also vice chair of faculty affairs and achievement, as well as vice chair of education and faculty development at Baylor College of Medicine. He completed medical school at Baylor College of Medicine, got his residency training at the University of Chicago, and a master's of education with focus on health professions from the University of Houston. Prior to his current role as vice chair of education and vice chair of faculty affairs, Dr. Pillow also served as the residency and clerkship director for Baylor College of Medicine. Dr. Pillow has essentially a very illustrious history, all in getting us to be better educators and take in information in kind of new, exciting ways. So we are happy to have him here. And without further ado, Dr. Tyson Pillow.
Yeah, absolutely. Thank you for having me.
Yeah, thanks so much for being here.
Absolutely.
Can you tell us about your background in emergency medicine and how you became interested in med ed?
Absolutely. I would say it's been a God-given gift to be born and to be on a path for emergency medicine and education. I can remember back at Rice University, Houston, Texas, when I was doing undergrad. One day I saw one of my future friends and colleagues walking around in his EMS suit with a defibrillator. I said, that looks cool. What's that? And that put me on the road towards EMS. I served as an EMS lieutenant for the college-based service. On that path, emergency medicine. Actually got my paramedic while I was still a student at Rice. I was only, I think, the second paramedic as a college student at Rice University. I went on to Baylor for medical school, at University of Chicago for residency. At University of Chicago, I'd always been interested. I love to think and how we think. And so it lends itself very nicely to education. I was the chief resident for education at the University of Chicago in my third year. Spent a lot of time developing a career focused on resident education. I was blessed to have the opportunity to come to Baylor College of Medicine, not only help build a program from scratch, but also be its second program director. But then from there, opportunities for faculty development, medical student education, resident education, of course, EMS, and just really love the process of learning, thinking, understanding. And it really lends itself to technology as well, because the landscape's changing so much. For those of us, we aren't digital natives, but we've been here while it's just been built. And being at the cusp of something like this, where you're seeing it develop around you, has been really exciting. So that's a brief summary of where I'm at now.
That's great, Dr. Pillow. Amazing intro. How would you define AI in the healthcare space? Like for those who might be new to the field, how do you picture it?
Absolutely. I think the functional definition, I like to think of it from a process standpoint and really understanding the fundamentals and basic. It is a tool, right? So these are really, artificial intelligence is mostly computers, right? Thinking about modeling human behaviors, human tasks, right? And we've had some aspect of this earlier, but they've just gotten better, right? We had Siri before Siri was infused with AI, for example, and she seemed to be able to anticipate your needs. She was always listening, by the way, but it's just gotten better and better, where the intelligence, again, mimicking human tasks, mimicking human intelligence, has just become more intuitive and more in tune with the way we think, the way we function, the way we live, really. So that's how I try to define it to people that ask.
It's great.
I think maybe it was a natural segue for you, but I'm going to go ahead and ask anyways. What was it that sparked your interest in combining AI applications in medical education? Because I think there's a lot of promise there, but maybe a lot of less know-how, and certainly a lot of less, let's go ahead and let's do this.
Absolutely. I think, again, coming back to this idea of the process, if you look at a lot of my early work, I was actually one of the first people to speak nationally around, for example, presentation design. And you can actually go back. It was one of my passions very early on. And even in looking at PowerPoint as a tool, PowerPoint is a very interesting model for this same question. When PowerPoint came around, there are tons of articles talking about the evils of PowerPoint. And how could you possibly take away my 35 millimeter slides? And what are you doing? And then even as it got integrated, there's still bad PowerPoint. Our first PowerPoints were just, you try to put a book on a slide, right?
Yeah,
And then
yeah.
you would go to parties, you're like, oh, how long was your PowerPoint? Mine was 200 slides. I put a whole auditorium to sleep. So there's something to this integration, right? New tools. We try to figure out what to do with them. We try to figure out how to bring them in. And so this is just another sort of opportunity for that. What's really exciting about AI, and I love this because this is the same sort of mindset that says, hey, why don't I start my career by building an EM program at an institution that doesn't have EM and has largely not been very pro-EM for the last 20, 30 years. That sounds like a great idea, right? If the thing, you look at yourself and you challenge yourself and you try to push. And so you see this technology, you're like, wow, this not only pushes our understanding of the tech, it pushes our understanding of ourselves, which is really exciting. We have to look at education. Again, we have to look at the practice of emergency medicine, right? I remember going back a little bit to my speaking career. I humbly and respectfully submit that at one conference I spoke, I told someone that I hadn't read one of the main texts front to back in emergency medicine. I used it as a reference. And there was like an audible gasp. You read it? How could you possibly know? And so we're understanding through AI how to understand things better and what knowledge is and what the practice of medicine is and what education is. And so that's my lens at coming at it, thinking about this amazing tool in front of you and what can it do. So, and it's a lot of guess and check too. I think the other thing, right? You try it out. Okay, that didn't work. Try that again. Oh, that worked. Oh, that was nice, right? That's very EM, isn't it? All the jokes about, for those of you all listening to us that are old enough to know when I say MacGyver, right? Which is a dated joke nowadays, right? We still get it. MacGyver. You mean MacGruber from Saturday Night Live? No, MacGyver.
The Richard Dean Anderson.
There you go.
We're talking toothpick, rubber band, and straw, and let's get a ventilator going.
Yeah.
Right? And so if we can do that, a technology that's as powerful and has so much promise as AI, how could you grab it?
Yeah. No,
That's great. Yeah, that's amazing. We wanted to highlight one of the papers that you published in Medical Teachers. It looks like in June of 2024. Not to put you on the spot, but we wanted to get a kind of sense for this particular publication called 12 Tips on Creating and Using Custom GPTs to Enhance Health Professions Education. I don't know if you want to just walk us through the project and talk about, in the context of medical education, how some of these generative AI models are going to really change the landscape of medical education.
So that paper, first and foremost, I want to give a shout out to all of the authors on that paper. It's an amazing group. And I did not lead this paper, but was able to be part of this group that developed this. A particular shout out to Ken Masters, who was doing technology in medical education before it was cool, before AI came out, and has continued to be a leader, as well as our own at Baylor College of Medicine, Jennifer Benjamin, who continues to be a real leader in the AI space, nationally and internationally. And coming to this group, we actually started work around this idea of connectivism and how technology fosters the sharing of knowledge in different ways than we've thought about before. And that group was already formed and in place when AI started to blossom and come more to the mainstream. And so we just jumped on the opportunity. This is a very interesting paper because it's a microcosm, the challenges and the potential in AI, as well as the reality, right? I'll cover the reality first. The Dr. Masters was the one that led the writing of this particular paper, and in record time, we wrote this paper very quickly. Even with a very quick turnaround on writing the paper and getting it published, it was largely outdated once we published it, which was mind-blowing, right?
Yep.
We're sitting here, we're like, oh yeah, you can create custom GPTs and you do this. They already got like 100 businesses that do that for various things. So it's very interesting. However, I think it still holds tremendous value because it's an attempt to start to translate AI's potential into tangible, usable pieces for health profession educators. And we really just touched the surface, right? Especially for a 12th DIS tape, but that's what you do. But we come in and we try to help people understand very briefly what is this AI thing, what's ChatGPT and what is GPT? How do we think about it? How do we use it? How do we think about the security concerns and that framework that's necessary? But really diving into, here's how you explore it. Here's how you build it. Here's some ideas. And that's really what it is. It's ideas around how you might make this tool yours, how you might take this and develop something that's useful for your context. And I think that's what's exciting and continues to give the paper value long after. I mean, you all know this. Early iterations of OpenAI, you really had to be a computer programmer, right? To get the prompts where they needed to be, right? Now, if you think out loud too close to a computer,
It'll predict what you want.
Right, it does.
Yeah.
And so the technology moves so quickly, and a lot of these great companies producing great software are really companies that have said, you know what, we are going to create this type of custom GPT, and we think this type of custom GPT will be useful for these users, right? So a lot of these apps and things we're using are just someone that went in and built that custom GPT that you would find useful, right?
Yeah.
It's still value in the paper itself because it really is an exploration of how would you approach this? How do you think about this challenge? How do you build? How do you start to take into consideration the type of things you need to do to make it relevant for your context? And I think that's always going to be a question we're asking ourselves, even as the AI continues to evolve.
Yeah, absolutely. And I think when I read the paper, first of all, congratulations and kudos to you, because I think it's a very needed paper in the fact that so much of what happens in the discourse of artificial intelligence is not necessarily immediately understandable to the vast majority of people, is how that would apply to them in kind of XYZ scenario. And you were very purposeful about not only saying how this could be helpful, but here are some scenarios, right? And here's how you would set that up. So I encourage anyone listening, if you are in the med ed space, to definitely go check this out, even though it does talk about GPT-4, and we are
That's so yesterday.
Right. Well, it's so funny. I was just talking about with my friend, and I was like, I really am just trying to, we're at the end of the year, and if I think back 1 year, it's crazy how far we've come. Right?
Yeah.
4 was the standard, but it had just come out. Realistically, we're talking about 3.5. You weren't uploading multimodal PDFs that were very long. And there's just so much changes. You didn't have agents. You didn't have all these things. And then I was trying to, okay, so let's prognosticate forward 1 year. What did we think was going to be the biggest innovation coming out within that time? And I had a joke that I didn't even know what was going to happen at the end of December, given that OpenAI has this 12 days of gifts thing. It is just, there's so much out there. There's so many tools, including and beyond ChatGPT. What did you found most valuable in medical education and why?
Are you asking from the terms of product specifically, or how? Are there so many ways to think about that?
That's a great way. So I guess first, let's do products. What are you using when outside of GPT or Claude? Maybe you're doing some open source Gemini or Mistral, but out of just the large language models themselves. You had mentioned that there are these customized agents. You gave, again, I think a great bevy of kind of use cases in the paper. What are you actually doing in your day to day?
Yeah, so that's interesting. I'm trying for those that are in Baylor College of Medicine leadership that have supplied us with amazing software tools to use. I'm trying to use things like a Copilot in Teams and otherwise, right? What I found is, and that is both anticlimactic, but also key critical, right? Because on one end, I appreciate the praise that you've given me for the talks and things we've done. I also am awe. So when we were at the National Medical Association, at this point, we essentially give our hour of AI together, right? And it's very interesting to see where people are at, right? So we've got people like yourselves who are dropping the names and up on the most recent AI developments, but the large majority of people are saying things like, I use AI to save $500 on my cruise, right? And that's real. And there are the education parallels, right? I use AI to make 3 of my slides, and they were good slides. And so I find myself more so nowadays, rather than trying to stay on the cutting edge of types of AI, I'm actually diving into the AI tools being integrated into tools we already use. And it's very interesting to see because I feel like my role, again, focusing on that process, is to help people translate the promise into actual palpable things, right? Educational products, learning objects, curricula, instruction, whatever it may be, right? And on top of that, though, I will say I do, for example, I use Zapier a lot before it started to have the AI tools. Automation is absolutely a thing. So I do use a lot of AI automation functions to make life easier. I will say that not to plug any one app per se, but open evidence has become a go-to. If you're
Agreed.
practicing medicine and you're not looking at open evidence at some level, it would be like, if you go back 10, 12 years, what? You don't use up to date? What are you talking about? So now in 2024, going to 25, what? You haven't looked at open evidence? What are you doing?
Yeah, great
Right?
product.
Oh
Yeah.
my goodness, absolutely.
Yeah.
With the caveat being too, this is why I try to tell people about the things I'm excited about, but also not get locked into single products. Tomorrow, there might be the new, by the time Ethan looks like he's very much on the production. This is probably going to be up about 10 minutes after we talk. Even then, we could be outdated as we're recording it, right? The new product might have already hit. We all haven't seen it because we're here recording this right now. And so keeping an open mind to the other pieces that are there. I also think there's benefit to telling people to try apps within the things they do with their life. Amazon already had a time machine, right? You hit the one touch button and your product was already on your porch. So that's already there. Now with other things like that. So if you do shopping, you do family management, your management, right? EMRs, we haven't even gotten to that world. And I'm not very much part of that world. I know that you are. In a lot of the QI work and AI work you're doing from the operations side, but it's already integral into what we do. So my focus has been less so some of the newer cutting edge AI and more, all right, how do we really make it work for our day-to-day application? And so like I said, I'm in Teams. I've used a scheduling software forever. If you're not making your scheduling life easier, especially as a busy clinician academician, I think you're missing out on opportunities. And so that's where I'm putting more of my effort.
Diving really into medical education, where are you seeing like kind of residents utilizing these tools? Is there a particular sort of moment where you've noticed that residents' AI made a memorable impact on their learning experience? And that could also be a negative as well, transforming the way that residents are learning, especially in emergency medicine.
Mm-hmm.
What have you observed in these last years where we've seen this phenomenal growth of the technology?
So that's a great question. I think I'll start by talking about globally. Again, getting to my excitement about AI. AI as a new technology. And I will also point people to, I think it's Han et al., HAN. It defined education technology as a process. So it was one of the sort of key papers you should read if you're into education technology. The thing about AI, well, one of the many things about AI is that it makes us relook at everything, right? We have built medical education, training, etc., around the premise that you must maintain a certain amount of knowledge in your brain that the better people are the ones who are able to maintain larger amounts of those facts in their brain and recall them at any time. And in fact, we have entire TV shows around the fact, like House, which I like watching, and then other shows. The people that can remember the most esoteric things at key times, those are to be celebrated. Now we are moving to this era where the people that can integrate this tech into their practice the most seamlessly are going to be the most successful.
Yeah.
Right? And so it's really, so residents in particular are part of this shift. And residents are interesting too, because residency is where that knowledge meets practice, right? High school, it's really, all right, I gotta be pretty popular. I want to try to, or at least try to figure out who I am in life. I gotta make sure I have fun at the prom. Get into college, right? College is, all right, let me survive. Let me show my family I've got some sense. Keep it together, get to med school. Okay, great. Med school, learning all these facts. I have a short white coat. I think everybody knows that I don't know what I'm doing. I have a safe distance. You get to residency, and now your knowledge affect that patient's care.
Yeah.
Right. And so residency is a great sort of lens to look at, because it is really where it translates from the theoretical to the practical. And it's really challenged us to look at resident education. Right. So we have measured resident education for so long based on test scores. Right. We got to move away from that, because now I got something that can help me ace the test. In fact, I have a tool that can tell me a better answer than the one I knew yesterday. How do you integrate that into care? And I think that is where that impact has happened, where I try to, one of my life examples I give in thinking about technology and thinking about thinking. I had a very sick patient, and I will openly admit I had no idea what to do with this patient. I did not know why they were sick, but I relied on my knowledge process, emergency medicine. So let's stabilize them, ABCs, reevaluate, reassess, use our ultrasound, use our tools. And in that process, we are actively looking up answer based on our finding, inputting that data and using that data real time to change our decision-making pathways. And that very sick patient at the tail end of the COVID era, ending up with a new murmur, with maybe some cardiomyopathy, with recent travel to somewhere in sub-Saharan Africa, the classic like EM test question.
Yeah.
He walks out of the hospital alive because we were able to integrate our training with information that we iteratively improved as we were taking care of the patient, right? That is the promise. And that's where you get that aha moment, right? This is what it's about. And yes, I needed to know the dose. You got to know your RSI medications, right? It can get a little tough to have to pause and remember.
Hold on a second.
Keep breathing for a second. I'm intubating you, but go ahead, keep breathing for a second. So there are absolutely a few things that you need to know and refresh yourself with frequently. With that said, I would say even in critical patients, and from my own experience, integrating that information transfer and using AI and tools to actively make better decisions translates to bedside care and better care. And that's where you're seeing it with the residents, where they get it, right? It's not a threat. It's not oh my goodness, this is going to take my job. It's, oh, this makes me better at my job.
Yeah.
We're in a great place to expand our repertoire with this tool. So you can imagine being in position to not be a radiologist yourself, but feel relatively confident in kind of a read that was done by a virtual AI program that's 99% sensitive for picking up stroke. And that can go on to every specialty has a thing that we see pretty regularly in the emergency department that maybe, shortly here, that may become more of in our domain.
Absolutely. Right? And in that context too, it is not lost on me, my Matrix reference in terms of AI. But with that said, I commonly imagine it's going to be like flying the Black Hawk. right? You're going to go in a room and you're going to be taking care of a patient. And you're like, not exactly sure what's going on. And you're going to hit your AI button. And you're like, oh, I can fly Black Hawk now, right?
Yeah.
And we are the perfect people for that. We are absolutely, right? You got us, critical care, a little bit more of the high intensity adrenaline bedside sort of management. Not to say that everyone can't benefit, but we're perfect for that. That the generalist who needs to become a specialist at certain times in their practice, right?
Yeah.
I literally just thought of that with you all. Talk right. The generals that have to say. And so then, it changes the way we educate. It changes the way. How dare you pull us aside and do a 30-minute talk on X, right? That has a place. Don't get me wrong, right? That still has a place, but more of it should be, we are right next to the bed. Here's how I would use AI to help me right here. Right?
Yeah. Yeah. And also I think patients are probably using it too, right? As they're getting the real-time data coming in my chart, they're probably also plugging it in as well. So you have to keep up with the patient side, which I think is also an interesting sort of perspective.
So I recently had my annual physical, so I am nice and healthy, which I'm very excited about. I got my chart data. Like, there is a lot of data here.
Sure is.
I know a lot about myself right now, right?
Yeah,
And so
yeah.
absolutely they're using it. And then I don't know if you all saw or aware, I put this in my talk, the AI chatbots are better than us at answering patients' concerns.
Absolutely.
Right? So how do you integrate that, right? How do you educate residents to be outstanding clinicians with AI rather than, study over here with AI, but practice medicine over there?
Thought of a really hilarious scenario where someone who's, I have a really hard time empathizing with the patient or coming across as empathizing could learn that skill from a voice agent or something like that, which would be a weird twist of fate, huh?
Yeah.
So not only is it coming, what's really interesting is I think it's going to happen with our non-English, non-Spanish, or I should say non-English. My own population of non-English, non-Spanish primarily, but that I'm concerned about when I speak pretty good Spanish, but in our non-English patients, all the tech coming out that's going to be infused with AI, right? And so we're going to be able to put in, you won't call an interpreter pretty soon. You're going to put in headphones and they're going to talk and you're going to hear what they're saying in your language and you'll be able to speak back and they'll be able to hear what you say. And then AI is going to try to make it better. You're going to say, I'm really worried about this and it could be anything. We're very concerned, but we're going to do our best to take care of you. It's going to make it better.
So now I get to be a nerd because this is, I'm pretty sure, the universal translator from Star Trek that I've been waiting on my whole life.
Yeah.
And when life imitates science fiction, it's the best.
Absolutely. And tricorders. I've made so many jokes about tricorders and people look at me like, what is that from? Because no one watch old school Star Trek anymore. To be able to go bedside, put a probe near them, sounds like an ultrasound.
Sure
now
does.
that ultrasound's talking back to you and giving you indications of high and low levels.
A lot of potential, and there's a lot of ways you could use it within the realm of kind of resident education. Are you doing kind of sim, or are you using it to teach interprofessional skills? Kind of the things that are laid out in the paper. Have you been able to integrate that at your own shop?
Yeah. My disclaimer is that although my life largely started as medical student and resident education, I have shifted really to educator education. And so we're educating the people that are educating students and educating residents from that standpoint. So more from that lens, but also when I'm clinical working with residents, it is try to find ways. So one of the things that I have become enamored with is teaching residents to question their own thinking while they're thinking it.
That's great.
And that is critical because what that allows you to do is to explore things you don't know. The best example is like a rash. So you're looking at a rash. We're more comfortable not realizing we don't know what rashes are, right? I would say, rough estimate, I would say 95 to 97% of ER docs are like, call ID. Huh? Send them to the PEZR. It's probably a kid, right?
Yeah,
And then maybe 5 to 7% are like, oh yeah, that's seborrheic keratosis with the abnormal presentation. So that's great. So we know we have gaps there. We're very prone to looking at the resources there. What I'm trying to use AI in education, and then really fun teaching educators to teach residents and students, is to use their resources, including AI, primarily AI, but including AI, to question their own thinking. So you come in and you're dealing with this patient and they've got a cough and they look pretty good. X-ray's a little hazy. They're 93% on room air, COVID negative, right? You're looking at them, don't think they have a PE. Maybe somebody sent a dimer from triage, it's negative, etc. Right? At the end of the day, you will absolutely get people that say, okay, I think I know what this is. I'm going to do this, right? Feed that into an AI model and see what it says and just challenge yourself, right? It's a version of that classic, oh, the student note wrote the correct diagnosis, doctor. Why didn't you consider atypical iliac artery dissection with blah, blah, blah? So it's the chance to challenge your own thinking and reinforce those processes. And it's really interesting to educate around that because it's counterintuitive to the way we learn. Multiple choice question, patient has right lower quadrant pain, fever, vomiting, anorexia, and a white count in the male with A, B, C, D, E. Happy all day, right? Any of our ERs, patient has fever, right lower quadrant pain, nausea, vomiting, anorexia, white count. Torsion, atypical presentation of torsion. Is this androgen insensitivity with the undescended testes? Is this situs inversus? We know to think beyond that linear sort of one answer thinking. And I think AI helps us to do that. And so then you educate around challenging yourself with this tool, with that knowledge.
That's great. Wow. Do you think, are there specific tools? Emergency medicine is certainly a very unique specialty. And dovetailing on what you just described, are there certain tools you think that are, from the AI perspective, that are more effective for teaching emergency medicine learners as opposed to other specialties? Because I think we certainly practice in a unique, chaotic environment, and there's certain tools that probably work better for at least learners than some of the other tools. I'm not sure if you have any sort of thoughts on that.
Yeah, so I agree with that statement that there's likely a subset of tools that are better in the ED. I have not found them yet. I wish I could have the answer. What I will say is that there are certain processes with AI that tend to work better, right? Because especially clinical education, you are educating as you're taking care of the patient. So there needs to be that flow piece as well, right? And so I find that when I'm able to ask definitive questions and ask them to, so if you go tell a learner, go look up this thing on AI, I'll see you next shift, right? It's going to, right?
Yeah.
But if you give them specific questions to answer with that AI tool, right? What's the chance we're missing X with this presentation? Has there been any signs of foodborne illness in our region recently that might present like this? When you ask them a little bit more definitive questions with the tools, then there's more effective answering of questions in the context of patient care, and it flows better, right? I will also say, once again, maybe I should own some stock. I need to think about that. Open evidence.
Yeah.
Oh, man. I really hope listeners go to it and look at it. That's starting to look the way we think, right? That comes out, and it's nice, quick, short bites, right? It's that bridge between up to date, right? Where you're reading about a topic, and that topic's close to what you want, but not quite, and you're pulling from 2 or 3 articles versus a synthesis right there in front of you. So I also challenging the resident to justify their reasoning. Even on things, and here's the key, I will say for education, that's definitely fun with AI, even on things they think they know, right? So you get a patient who's getting admitted for high-risk chest pain, and the resident says, yeah, I'm admitting him. I gave him an aspirin, and they're otherwise stable. Why'd you give an aspirin? And they look at me like I'm crazy, like, you're supposed to give an aspirin. But yeah, why did you give an aspirin? Because the hospital told me to give an aspirin. And so they actually get to explore and obviously you're supposed to give an aspirin. Aspirin reduces mortality by 50%. I think it's a study showed 6 out of 100 versus 3 out of 100 to decrease the risk of MI. Many people haven't read that landmark study, but that's why we give it. And so you're able to challenge around that. In summary, I have not found the tools yet that are specific to that need, but I've found some strategies that seem to work a little bit better for the EM world. And maybe we should, 3 of us, start a business and create that for EM. That would be the thing. And then again, my plug for open evidence. It's amazing.
Yeah.
I actually will follow up with the open evidence plug, which I do second, and just say for anyone listening in, it is actually free if you have essentially a hospital or education affiliated account. I don't know how long that will last because it is a valuable resource and they are probably chewing through compute, I imagine. But as long as it is there in this beta stage, I definitely recommend you take some time and just play around with these tools. So many of these tools, and I think maybe you'd agree, is just going out, like you said, it's like emergency medicine, just seeing how they fit. They fit your workflow. And if they do, figuring out how to make them your own a little bit. When it comes towards getting your residents to model that same behavior, I think when I look back, I am just old enough to have really come up with the advent of foam medicine, so free open access medical education, which was a whole movement. And I think AI now takes that and, I don't know, kicks it into outer space or puts it on overdrive. How do you recommend balancing AI enhanced learning? So you said you weren't sure of the name of this particular text, and I'm not really sure that is important at all anymore, but how do we make sure we're still staying grounded in the same base of knowledge if we're all customizing our agents and tailoring in on our own education? How do you balance all of that?
Absolutely. Yeah. And so that is, again, it falls back to a strategy rather than a particular tech I've found. And that's 2 pieces in my sort of life examples of it and where I'm at right now. And one is, you're right, it kicks foam into like high gear, right? So foam was this idea of not only free open access medical information and content, but also in general, people consider foam to be more up to date than the books. And so now AI brings all of that to your fingertips in real time. And so I challenge people with 2 things, very important in the context of safety net hospitals as well. So we're a safety net hospital in Houston, Texas, is what's that evidence, right? I'll say this, and I like to make sure to contextualize and beyond some of my education. The last I read about X, this was the best thing to do. What's the evidence say about it right now? And then they get to bring in AI, get to bring in the evidence, bring in their foam, all that great stuff. Great. Now, with all that information, what are we going to do for this patient today? And I think that's a critical piece, because having the information is just part of the process of caring for that patient. And speaking to the education, right? Focusing on the education piece, you've got to model it. You've got to model it yourself, where you're asking the questions, but then bringing in that practical piece. And so, yes, I mean, there was a time when, so for example, I've always had around neurologic diseases as well. And so there was a time where Keppra has probably been the best medication for seizures for a very long time. That's a very broad general statement. There's some evidence around that, and I'll be happy to debate it with anybody. With that said, there's a time where Keppra was like, hey, you got to have a good job with good insurance to get this drug. And so, yes, you have this aspect of clinical evidence, but then you also have this aspect of just real life medicine, right? What can I do here? And again, that's one of those things that more technology, I think you're going to see integrate that in, right? And that's part of the draw of open evidence and other sources too, that are able to say, yeah, not only is this the evidence, but here's how I would use it. So it really is that challenge of modeling it from an education standpoint, and then teaching other faculty. That's probably one of the hardest things. Honestly, we've been doing this so well for so long. Now that this tool that's come around has challenged us to do it better, I would argue we don't always know how. And so teaching educators to educate in this context is also another challenge that modeling is another strong sort of strategy for that as well.
I think one of the topics we try to hit on, which is obviously another separate hour conversation, is bias in AI. So we know that the models are biased. They're based on our society, on the data that we have. How do you think, or what sort of safeguards should we be putting in place when using AI for medical education to try to address or mitigate a bias that we know exists in these models and can affect patient care?
Absolutely. So my disclaimer here will be, while I also speak nationally on implicit bias, unconscious bias, and those sort of topics, in the world of AI, I am still learning literature and learning from others when we're looking at this. What I like to think about is that the idea, and forgive me for putting some of these concepts a little bit bluntly or generalizing a bit, but it learned its bias from us. We didn't input perfection and then something happened. So I think it is, I toy with the idea sometimes, again, potentially a little controversial. What's a little controversy? Is that it's as biased as we are.
Yeah.
And gives us a chance to look at our biases. I like to really pull that out. And for those of y'all that haven't done the experiments, you can do this. Go to OpenAI, ChatGPT, go to whatever sort of free text AI agent you want to, and ask it to do something like, let's write a letter as if you were writing as a woman. And it chooses words. So like, now write as a man. Chooses different words. Now write as a African-American man. Now write as a Mexican-American. It changes the tone. One pseudo-famous experiment was asking it to write a letter of rec for a man versus a woman. So the woman's letter of rec is nurturing, supportive, right? The man, leader, strong, right? It learned it from us.
Right.
And rather than, and so I'm not necessarily on the, I'm not in the bandwagon that says, all right, AI is biased, we can't use it. I'm in the bandwagon that says, wow, AI really puts a light on us, doesn't it? So what are we doing already to manage our own biases? And what do we need to continue to build into this using AI? Because it takes away, if AI tells you this is the answer, right? If Ethan came up and said, hey, Pillow, based on what I think, this is going to be your answer. And then AI told me something different. Well, Ethan, sure.
Yeah,
The assumption that it's right. And so it really challenges us to continue to ask. And I think it puts a light on our own practices and our own biases. And so then, we have to build in, the second part of your question was, how do we mitigate that? We have to build in those purposeful pauses, all those strategies that we currently use, right? Looking at our risk, looking at data, right? There is nothing like, and this doesn't work every time, but every once in a while, I'll have a resident talk about, for another example, I do a lot of pain management talks as well and teaching. And so the resident will come in and let's say patient had an MVC, their femur's in several pieces. And I see that the resident has ordered a 650 milligram dose of Tylenol.
Yeah.
So you get to have the talk. I'm like, oh no, I get narcotics all the time. Okay. Let's pull up your last 10 patients.
Yep.
And so how do we work that in with AI as well? So we need, so it shines a light on what was already there.
Yep.
Has the ability to make us look at ourselves a little bit more directly. And we need those same, if not better, processes around AI that we should have for ourselves, quite honestly.
Yeah. Oh, that's amazing.
All right. Well, this has been an amazing conversation so far, and I think we should close it out with kind of an uplifting tone. So what excites you most about the future of AI in medical education and emergency medicine? You don't have to pick either or. You can do both or neither, which just, what excites you most about what's coming next? or what you think is coming next.
Absolutely.
Yeah.
I have two young ones myself. I've got a 10-year-old, 7-year-old. And to watch them navigate technology and at times, not all the time, but at times interact with AI in ways I could not have imagined is incredibly exciting.
Yeah.
To know that I was doing with our old education, so I grew up in St. Louis, Missouri, wonderful city to grow up. I had a chance to have a pretty good education. My parents sacrificed tremendously to give us the best education we could get. So I was doing pre-algebra around, I guess, about like 7th to 8th grade or so, or something like that. To see my 10-year-old who's in 6th grade already doing some of those equations, and to have my 7-year-old they're both really smart, to have my 7-year-old already doing like what I would call pre-algebra, supplemented by technology that gives him feedback about his performance right now. Like, just seeing that in action, we're going to go further. We're going to go further faster, right? Yeah. That's the excitement. And then what is our role in that? And I know it can be scary. You've got listeners that are like, yeah, AI, but it is absolutely an unknown. And when you think about that unknown, there's that calling to drive it, right? To be part of it and to take it where we want to, right? To design our future in a way that's just better, right? That's the excitement around the AI that is exponentially getting better and faster, right? And we take a lot of it for granted, right? We hold in our hand more computing power every day than the entirety of the 1980s, 90s, and maybe even early I don't know.
Yeah,
I'm just throwing out, right?
Yeah.
So where can it go, right? That's exciting. How many more people can I take care of with the right tools? How much better can we educate? Can we care for patients? Can we share information? Can we just grow with the right tools in the right place, with the right synergies?
Yeah, agreed. I think I can't add anything to that. Ethan, you got?
No, I think it's amazing. Yeah. I don't have anything to build on that. I think that's incredibly inspirational. And I think, yeah, I'm excited even for starting with the youngest learners all the way to our EM residents. So I totally agree.
I really, again, just want to appreciate you for coming here and talking with us today. It's a really vital topic, but I think you're just a great spokesman for it because you're really able to distill it down to what I think are the key parts that are going to matter going forward, right? And when we're talking about applying it in a residency program or teaching educators, really, we got to start getting our hands dirty and figuring out the right approach, because it doesn't sound like either it should be or like we really would want it to be a one-size-fits-all approach.
If we do one-size-fits-all, we did it wrong.
Exactly. So really, like I said, this was a great conversation. Thank you so much. You're official friend of the pod now, we like to say. Don't be a stranger. We'll get you back on here sometime soon.
Absolutely.
Yeah, thank you so much, Dr. Pillow. We really appreciate it. Yeah,
this was great. Thank you.
Thank you. Thanks so much for listening to episode 9 of the Stat AI podcast. We so much appreciate all of our listeners out there and looking forward to bringing you some more interesting interviews and content on all things AI and emergency medicine in 2025. Thanks again.
Please note that the views, opinions, and information expressed in this podcast are solely those of the individual speakers and do not necessarily represent those of their employers, our sponsors, or any affiliated organizations. The content provided is for informational and educational purposes and is not intended as medical advice. We encourage you to consult with qualified healthcare professionals for any medical concerns or treatment decisions. This podcast is not a substitute for professional medical advice, diagnosis, or treatment. Listener discretion is advised.